Assalamu alaikum. I'm Dr. Ahmed Lutfi. I'm a senior consultant obstetrician and gynecologist. I have been practicing in UK, New Zealand, and Middle East. My qualifications are MBCHB, master's degree, and MRCOG. This is a presentation about management of postpartum hemorrhage. The definition of PPH is vaginal bleeding more than 500 ml after childbirth or any loss causing cardiovascular instability. The types: primary within 24 hours, 70% due to atony, or secondary after 24 hours up to 6 weeks postpartum, often due to retained tissues or infection. Traditional definition: vaginal bleeding more than 500 ml. During cesarean section, the loss of 1000 ml should be considered as primary postpartum hemorrhage. Causes of PPH are 4 T's: the tone, uterine atony, tissue, retained placenta and clots; trauma, tears of uterus, cervix, vagina, and perineum; and coagulopathy, which is due to low platelets and is mentioned as thrombin. Problems: PPH is an obstetric emergency, can cause death within 2 hours if untreated. It is the leading cause of maternal mortality in sub-Saharan Africa. Diagnosis, symptoms, and signs: increased bleeding after childbirth, tachycardia and hypotension, decreased consciousness, floppy distended uterus, tears in the perineum, cervix, or in the uterus, retained products of conception, coagulopathy, and bleeding tendency. These symptoms and signs should be considered, and immediate involvement of a senior obstetrician should be done. General measures: initial management, call for help, from a senior team. Massage uterus to stimulate contraction, give 10 units oxytocin intramuscular. Insert wide pore IV lines, take blood for cross-matching, infuse IV fluids, saline, apply anti-shock garment if available to reduce any blood in the peripheries. Insert urine catheter, monitor vital signs and urine output. Uterine atony management: continue uterine massage. Oxytocin 20-40 international units in 1 liter fluid at 60 drops per minute. Continue at 40 drops per minute for more than 6 hours. The traditional Cinto drip in UK is 40 units in 500 ml of saline, and you give 125 ml per hour over 24 hours. If available, carbitocin 100 microgram IV or IM. It has a longer action. If no syntocinon or oxytocin or carbitocin, ergometrin could be used. Misoprostol 800 microgram sublingual could sort out the atonic bleeding. Tranexamic acid 1 gram intravenously within 3 hours of birth, and repeat after 30 minutes if needed. It was shown that tranexamic acid improves survival in cases of primary postpartum hemorrhage. If bleeding persists, bimanual uterine compression, consider balloon tamponade, Packett's balloon. If still bleeding, laparotomy for uterine and ovarian artery ligations, B-Lynch suture, bilateral internal iliac artery ligations, subtotal abdominal hysterectomy. All of this can be done. It depends about the experience and the skills of the obstetrician. Start to broad-spectrum antibiotics and ensure blood availability and transfuse if hemoglobin is less than 7 grams or the patient is unstable. Retain placental tissues. Repeat the oxytocin IV and controlled cord traction. Insert catheter. Manual removal of placenta under analgesia in theaters. Evacuation of retained products if needed. Tears in cervix and vagina should be sutured to close any tear and to stop any bleeding. Inversion of uterus. This should be corrected immediately, manually. And if this failed, then we administer 10 units syncytin IV. And the syncytin should be administered after collection. After correction, if it is unsuccessful, immediately perform laparotomy and correct the inversion. Thank you. This is the end of the presentation.